Good morning, everyone. Welcome back again to another edition of Cardiovascular Medicine Grand Rounds. This morning, we have a couple of quick announcements. I think at this time around, we should start thinking about nominations for the next year's speakers. We'll look forward to sending out a questionnaire to fill out for folks that you feel that should be members of the speaking group for the next year's session. Today, we are really honored to invite Dr. Colin Berry, who is with us today to talk about the stratified medicine in ischemic heart disease. Dr. Colin Berry holds a chair in cardiology and imaging in the University of Glasgow. He's director of research in the Golden Jubilee National Hospital and a consultant cardiologist at Queen Elizabeth University Hospital in Glasgow. Professor Berry is currently the executive editor of the European Heart Journal, senior consultant editor of the Eurointervention Journal, and editorial board member of Cardiovascular Research Journal. He's also the president-elect of the British Society of Cardiovascular MRI, magnetic resonance. During his training, he completed his medical training at the University of Glasgow, but has had advanced imaging training and research at Montreal Heart Institute and the National Institutes of Health at the NHLBI. Professor Berry's research focuses on two key areas: injury and repair pathways in MI and heart failure, as well as microvascular function of the heart. And these both topics seem to line really well with the topic of discussion today, which is stratified medicine in ischemic heart disease. With that introduction, Dr. Berry, welcome to Yale. We look forward to hearing from you.
Thank you very much, Rohan. I hope you can all hear me well and see the slides, and that my Scottish accent is okay for you. I have about 60 slides, but I plan to get through the talk in about 45 minutes or so. And then at the end, we can look forward to some questions. So, stratified medicine in ischemic heart disease. So these are my institutional disclosures. I hold no personal contracts. And I'm based, as mentioned, at the University of Glasgow in Scotland, UK. So in the coming minutes, I will describe to you three objectives: to create awareness on small vessel disease leading to angina, to describe stratified medicine, including endotypes and linked therapy, and then to consider future directions, including new and emerging clinical trials, systemic disease, sex disparities, and clinical guidelines. So let's consider the clinical setting. And this is from the perspective of the UK National Health Service, where there are chest pain clinics in most hospitals at the interface between primary and secondary care. And there are, I understand, around 1 million visits to these services in the UK each year. I imagine a similar context, but at a greater scale in the United States, including related healthcare expenditure. Currently, in light of clinical studies involving CT coronary angiography, notably the Scott Heart trial that I participated in, and then the NICE guidelines, the UK NICE guidelines, for a patient presenting with known or suspected angina, the default management is to request a CT coronary angiogram. We know from studies such as Scott Heart, where coronary artery imaging has been performed systematically in such populations, that at most 1 in 5 of these patients will have obstructive coronary artery disease. So this begs the question, what about the other patients? What about those with anginal symptoms that may be similar, indeed more acute and profound than those with obstructive disease, and yet there is no obvious explanation for their symptoms? I'm not suggesting that 4 in 5 of these patients have small vessel disease, but I am suggesting that a considerable proportion of them do. And we know that these patients will repeatedly attend primary and secondary care. Proportions of them will be admitted and readmitted to hospital. And indeed, there is an adverse longer-term prognostic implication. So what is small vessel disease? Well, I often look to the work of my late colleague, Dr. William Fulton, who's a cardiologist working in Glasgow in the 1950s and 1960s. And he developed a perfusion apparatus using a bismuth microsolution. Bismuth, of course, because it is radio-opaque. And in the Department of Pathology in Stobhill Hospital in Glasgow, he obtained explanted hearts at the time of post-mortem and infused these hearts at physiological levels of blood pressure. The hearts were submerged in saline, and a process of stereoarteriography was undertaken to reveal the image that you can see on the right. And what is striking here is, of course, the depiction of the microvessels, which can almost be appreciated individually, accepting, of course, that this is a 3D rendition. And Fulton did reveal microconnections, or indeed the subendocardial microplexus of microvessels from radial arteries penetrating from the epicardium down to the subendocardium. So that work was done 50 years ago, and here we are today. On the one hand, for our patients, we have an anatomical or arteriographic approach, which indeed he implemented ex vivo. However, there are limitations with that approach by CT coronary angiography or invasive angiography because ischemia and microvessels, at least in vivo, are not apparent. On the other hand, an alternative approach for patients with chest pain is a functional test, a classic stress test, be it involving different forms of imaging, PET, MRI, or stress echo. The limitation with that approach, of course, is the coronary circulation is invisible. So we have let's say, a conundrum. This is the classic paradigm that medicine has really shaped up to address coronary artery disease, atherosclerosis, revealed generally well by a coronary angiogram. But we know now about the microcirculation that is invisible on the angiogram. And if clinicians are not thinking about the microcirculation, which is perfectly understandable if they have no information therein, then they may miss conditions such as microvascular angina and vasospastic angina. And you might say, well, does that matter? Well, probably it does. So this is a population level study of patients passing through the cardiac catheter laboratories in Copenhagen, 1998 to 2009, and also population controls from the Copenhagen City Heart Study. Now, one of the gaps in this study is they did not measure microvascular disease, but the prognosis of MACE-free survival is plotted by the presence and extent of coronary atherosclerosis. But what is relevant here is that even asymptomatic individuals or individuals with mild atherosclerosis had an impaired prognosis compared to controls. And yes, there are data on prognosis linking baseline findings of microvascular impairment, either an elevation of microvascular resistance, which is IMR on the x-axis, if you look to the left, or coronary flow reserve on the y-axis. And this is a plot of individual patient data from a cohort study in Korea. And what this scatter plot clearly shows is that these metrics are not synonymous, that there is distinct and differing information contained within a measure of microvascular resistance, IMR, versus CFR. And when prognosis is mapped according to one or both of these metrics being abnormal based on, let's say, accepted criteria, if you look on the right to the plot for D, cumulative incidence of events in relation to a low CFR and a high IMR, the hazard ratio is 5.6 as compared to the group with normal data at baseline, a high CFR and low IMR. That would be normal. So measuring microvascular function is clinically meaningful. And here are the challenges in our clinical practice, where at least in my healthcare systems, the National Health Service, we work in very much cost-constrained environments at scale, busy clinics, variable access to stress tests, whether it's treadmill exercise testing, stress echo, and much less so stress perfusion MRI, and not at all PET. Increasingly, as I've mentioned, CT coronary angiography, which is reducing access to functional tests. And then to the cath lab, yes, coronary angiography, and possibly we can add adjunctive tests. But if we don't add adjunctive tests and we do not adopt stress testing in any form, then small vessel disease will pass generally undetected at all of these points in the care pathway. So there are adjunctive techniques now available for use in the cardiac catheter laboratory, mainly 2, maybe 3 vendors. But beyond diagnostic guide wires, we also have near inline processing of the angiogram, which is probably advancing the case for functional tests in the cath lab. The data mainly are based on coronary guide wire sensors. And one of the appealing aspects of such a sensor, let's say the pressure wire X, which involves thermodilution, integrating pressure and temperature, and flow is derived from changes in temperature, you can simultaneously get information on the guide wire using fractional flow reserve, on atherosclerosis at the level of the epicardial artery, on microvascular resistance, so-called high IMR in the microcirculation, or impaired vasodilator reserve, reduced CFR. And this information can be simultaneously acquired on an individual patient basis, which I find very appealing diagnostically in the catheter laboratory. So then if I walk you through this plot, if you look to the top left, diffuse epicardial disease, so that's a reduced FFR, and microvascular disease, it's a high IMR, and a low CFR's impaired vasodilator reserve. So these are a full house of abnormalities. But then there may be a focal coronary artery stenosis, reduced FFR, with preserved microcirculatory function. So that's an IMR less than 25 and a CFR greater than 2. If you look to the bottom left, this is a case of isolated microvascular disease. In this case, both IMR is increased and CFR is reduced, whereas FFR is normal in the absence of atherosclerosis in the coronary artery. Or bottom right, diffuse atherosclerosis in the conduit artery and the microcirculation. There is no flow limitation, so FFR is preserved, but there is microvascular dysfunction as reflected by a high IMR and reduced CFR. So these basic concepts are a premise for work that we have developed in our clinical research programs in the past years. We have also incorporated coronary reactivity testing using acetylcholine and GTN. If you look to the center part of this figure, I'll describe to you how beyond the angiogram, we can add functional tests in a meaningful way to diagnose, for example, microvascular angina on the right or vasospastic angina on the left. So the coronary angiogram in itself can be useful because we can identify myocardial bridging, and even there may be slow flow. Then passing a guide wire and using the thermodilution technique, which is very straightforward to do, you can pick up an impairment in flow reserve, such as a reduced CFR, or an increase in microvascular resistance, such as a high IMR or a high HMR, if a Doppler technique is used. And then follow on and infuse acetylcholine according to a protocol which really should be established within your cath lab and employed by individuals with training and experience. So acetylcholine can follow on immediately after the guide wire test. And if there's constriction at the microcirculation or at the epicardial artery, that is informative for microvascular spasm or epicardial spasm and vasospastic angina. And then in the case of abnormalities, a diagnosis can be made in relation to microvascular abnormalities, hence microvascular angina, or an isolated problem with conduit coronary spasm, and that would be vasospastic angina. And functional problems are best treated with a calcium channel blocker for symptoms, along with lifestyle and other preventative therapies such as statins. So just to consider this at an anatomical level, we coined the term an interventional diagnostic procedure, which is bringing together the guide wire and acetylcholine. So initially, fractional flow reserve localizes to the epicardial coronary artery. Coronary flow reserve takes into account the vasodilator potential of the whole coronary circulation according to the instrumented artery. The index of microvascular resistance reflects the microcirculation really. And then acetylcholine, when infused, can induce a loss of or reduction of flow where the artery diameter is preserved. That reflects microvascular spasm, or a localized spasm in the conduit coronary artery, if you will, a string sign appearance. And of course, whilst these appearances can be concerning, they can be relieved immediately by cessation of the acetylcholine and administration of GTN. So these abnormalities, any of these, coronary flow reserve, IMR, or a constriction response to acetylcholine, lead to a diagnosis of microvascular angina. This may be structural if it's a high IMR, or functional if it's a reduced CFR or spasm to acetylcholine, or indeed can be both structural and functional, or vasospastic angina if there is a localized problem in the conduit coronary artery in the presence or absence of a microvascular problem. So I've mentioned stratified medicine. What is this and how is it relevant? So stratified medicine is the identification of subgroups of patients, so-called endotypes, within an undifferentiated patient population, with these endotypes being identified or discriminated based on disease mechanisms and/or therapy responses. And this paradigm was described in a framework document authored by colleagues from the Medical Research Council back in 2015. And it reflects thinking and practice which has already been well established in oncology. So we introduced this in the form of a grant application through the Carmichael study back in 2014, 2015. And at that time, it got no traction, with a final statement on the return from the grant body stating, "Do not resubmit." Well, we were fortunate to gain funding for the Carmichael project in two forms, through the British Heart Foundation, and eventually we were able to do this study. So this study assessed stratified medicine in patients referred to the cardiac catheter laboratory for the investigation of possible angina. So this was a real-world population based in 2 hospitals in the west of Scotland, where the standard care approach was coronary angiography without functional testing. So we asked the question whether a clinical strategy of stratified medicine, that is invoking functional tests with linked treatment, might lead to improvements in diagnosis and patient well-being during follow-up. And the primary outcome was the Seattle Angina Questionnaire summary score. We screened patients at the time of arrival coming into the hospital for their angiogram. We undertook a range of questionnaires, and during a 12-month period, our fellow and myself, Dr. Tom Ford, and colleagues consented 391 patients undergoing clinically indicated coronary angiography. To our surprise, 47% of these patients had no obstructive coronary artery disease. 151 of those 185 patients were then randomized immediately in the catheter laboratory. 30-odd patients were not randomized for logistical reasons. So of the 151, what did we do? So the guide wire was passed. If the patients were randomized to the intervention group, the results were made available to the clinician immediately to reappraise their initial diagnosis based on the angiogram. If the patient was assigned to the control group, then this became a blinded procedure where the IDP, the guide wire, and the acetylcholine testing was performed without the results being made available to the clinician. So this was a blinded, randomized trial of stratified medicine versus standard care. Questionnaires were completed again at 6 months and indeed at 12 months. So the baseline characteristics of the patients are of some interest. So the average age was around 60 years. Interestingly, 3/4 of the patients in this randomized population were female, which is of course typically the opposite proportion to what we would normally see in a clinical study in ischemic heart disease. The median BMI was around 30, and there was a reasonably high prevalence of cardiovascular risk factors. So the patients completed questionnaires, notably the SAQ questionnaire, repeatedly, so at baseline and then 6 months, which was the primary outcome, and then we did continue follow-up to 12 months. So a higher score reflects less angina. So you can see that in the intervention group in red, a much higher summary score was achieved as compared to controls. This is the between group difference. And this difference overall was driven by improvements or attenuation, let's say, in physical limitation and indeed in angina frequency. This was associated with a change in diagnosis at baseline in half of the patients in the intervention group. So that, in other words, the clinician would make a statement such as saying, I think this patient has non-cardiac chest pain. And then the IMR and CFR results and the acetylcholine results were disclosed. And those results might point to a diagnosis, final diagnosis of microvascular angina, let's say with constriction. And so the treatment might have been changed from a beta blocker to a calcium channel blocker. But beyond those changes in diagnosis and treatment, there were also differences, let's say improvements in diagnostic certainty by providing this additional information. And there was a lower proportion of patients in the intervention group with a misdiagnosis. And of course, when the diagnosis changed, so did treatment. Beyond the SEQ, there were also improvements in quality of life reflected by the EQ5D and in treatment satisfaction. We continued follow-up to 12 months and looked at mechanisms. The patients came back at this point and we measured body weight and blood pressure. We also completed the DASI score. And there were some differences, favorable differences in body weight, blood pressure, and physical activity, probably driven by enhanced participation in cardiac rehabilitation. So this is the overall, let's say, central illustration for the Carmichael study. And this coincidentally tracked into clinical guidelines. So the European Society of Cardiology's Guideline Committee for Chronic Coronary Syndromes was operating during and after the publication of Carmichael. So in some ways, the timing was fortuitous. And this committee, with which I had no role or association, identified coronary function testing in the cath lab as a 2A recommendation for patients with no obstructive disease, and also applied some guideline recommendations for acetylcholine testing and indeed non-invasive ischemia testing. More recently, the chest pain guidelines from the North American societies reported just in November last year. And this is a flow diagram or decision pathway for patients with stable chest pain and suspected INOPA. Indeed, this figure is associated with reference citation for Carmichael. And I think rather than going through this in too much detail, it reflects the type of information that I've been sharing with you in relation to reclassification of an initial diagnosis based on an angiogram, let's say, according to preset criteria, either invasively or on the right-hand side of this plot, non-invasively, using quantitative PET, quantitative CMR. Thinking about practicalities with invasive diagnostic testing in the catheter laboratory, I commend this article to you, which was written by authors from the Covadis group, myself included, but there really are some terrific expertise within this group over the past 20, 30, even 40 years, working in the field of small vessel disease in the heart. So I've spent a good deal of time talking about invasive testing. What about non-invasive testing? And again, let's look to the work of Bill Fulton. And I initially described this subendocardial microplexus, which I think is very clearly revealed here, highlighted with the yellow arrow. And then if we consider data from pixel mapping of myocardial perfusion during hyperemia, which is the middle figure, versus at rest, which is on the right-hand side, you will see an attenuation in signal, which is the sort of dark purple, dark green area in the subendocardium of the left ventricle, with a relative deficit in perfusion versus hyperemia that is achieved in the epicardium. And this attenuation in perfusion matches the anatomical distribution of the microvessels in the subendocardium. And to my eye, this is a nice, the Fulton and pixel mapping that we now have at this present day presents a nice correlation between anatomy and function in relation to quantitative measurements of myocardial blood flow. And now, enabled by technical advances, we do have pixel mapping myocardial blood flow using stress perfusion MRI, which is, I think, becoming increasingly available in daily practice. Of course, such techniques have been available for a long time with PET. So it's good to see these developments. And this is an example of work done by a group in London, where they measured IMR and CFR in multiple coronary arteries in patients And on the same day, these patients underwent quantitative stress perfusion CMR. So if you look to the top of the plot, if the perfusion mapping reveals a regional perfusion defect, they have corresponded a value of 1.94 with an FFR ischemic threshold of 0.8. And if there are no regional perfusion defects on stress perfusion CMR, yet that myocardial blood flow is reduced, then again, in terms of correspondence with IMR, an MBF threshold of 2.25 had a high AUC. This is another publication recently from another group in London using 3T, and they found that an MPR of greater than 2.2 was consistent with a normal microcirculatory function, whereas an MPR of less than 2.2 would be consistent with microvascular disease. So I've described some of the recent data in relation to techniques and implementation in the catheter laboratory, and also non-invasively with stress perfusion CMR. I'd now like to share with you some thoughts on wider context. I've hinted that anatomical coronary angiography will lead to an underdiagnosis of microvascular disease, or indeed coronary vasomotion disorders. That is probably increasingly well understood. But this becomes much more relevant if you consider populations by sex. So in Carmichael, consent was undertaken before going into the catheter laboratory. So we had no knowledge of the possibility of coronary disease, and we consented effectively all comers as best we could who had a clinical indication for an angiogram. So of the 391 patients, I mentioned that 185, 47% had no obstructive coronary disease. In that group, at the registry level, 68% were female. Then if you consider those individuals in this registry with obstructive disease, 38% were female. In other words, the majority were male. Well, that perhaps doesn't come as a surprise, because we know well that obstructive disease associates with male sex, and certainly that might be explained by the effects of the protective effects of reproductive hormones, let's say, during reproductive life in women, and perhaps other factors as well. But this starts to become clinically quite interesting. If you consider our study, Carmichael, so now focusing on the randomized population, and compare the population of INOCA patients in Carmichael versus Orbita. And Orbita is let's say, a reference trial population of patients with single vessel coronary artery disease. And there are some striking differences between Carmichael and Orbita. You could take any other population of obstructive disease, and I suspect we might find broadly similar findings. So in Carmichael, 3/4 of the patients were female. In Orbita, 1/4 were female. And yet, if you take the metrics from the patient responses from the SAQ score, and keep in mind that SAQ was developed in the populations of patients mainly with obstructive disease, the level of symptom burden was much greater in the INOCA population than in the population of patients with obstructive disease. And indeed, that was also the case for quality of life. In Scott Hart, 4,146 patients were randomized in chest pain clinics across Scotland. Nearly half of these patients had the CT coronary angiogram. And of course, in this case, 60% of the patients with obstructive coronary artery disease were male. Then, as I've mentioned, if you look at the patients with small vessel disease in Carmichael, 3/4 of these patients were female. So there are striking differences by sex in the mechanism of angina at the level of the coronary circulation. So let's look at this from a different perspective and consider terminology. Coronary heart disease, or INOCA. If one refers to angina as a problem of CHD, or indeed a problem of coronary artery disease, then this introduces systematic bias against individuals who have angina but no obstructive coronary arteries. And of course, the majority of these individuals are female. So I do think, based on some reflection over the past months and years, that the way that medicine and cardiology has evolved has introduced inherent sex biases against individuals with angina due to small vessel disease, particularly women. And this is clinically relevant because whilst we are championing CT coronary angiography for the initial management of suspected angina in guidelines both in the North America and UK, it is the case that in Scott Heart, the symptoms in angina became worse in patients who were randomized to the CT coronary angiography group. And that could be because of a misdiagnosis and discontinuation of treatment in patients who had angina due to small vessel disease. So pause for thought in relation to the guidelines that have developed in the United Kingdom. And the patient voice is certainly increasing and gaining traction, including with funders such as the British Heart Foundation. And we have this interesting situation presently where there are different approaches recommended by guidelines. We have the ESC guidelines really recommending let's say a personalized approach. And I think it's fair to say that is also the case in the North American guidelines. But keep in mind that the UK NICE 95 guidelines unilaterally recommend CT coronary angiography as the first line test for all patients presenting with angina in the absence of a history of coronary disease. So in the interest of time, I'll keep things moving. I'd just like to highlight the wider implications for systemic health, systemic small vessel disease, because of course the circulation is a continuum between the brain, the retina, the heart, and the kidneys. And then I'd like to, just in the closing minutes, highlight some clinical trials and future directions. So our work in Glasgow has evolved over the past few years, and I highlighted that in my first grant application, at least in this area, we were invited not to resubmit again. And since then, we've followed a journey with some success, and we're grateful for the funding that we've had from the public funders, BHF and chief scientists. So now we have even more studies going on. We've developed what could be considered a family of core family studies, core CTCA, core MICA, core CMR, core PEF, including collaboration with John McMurray's group. And we've got larger clinical trials, which I'll just briefly describe to you just now. The core CTCA study involves evaluating microvascular function in patients who have anginal symptoms but have a clear coronary, the CT coronary angiogram, or at least an unobstructed angiogram. And we do quite the opposite of what normally happens. So rather than discharging these patients back to primary care, we invited them to have an invasive coronary angiogram, and then we implemented the IDP procedure and protocol as was described in Carmichael earlier. And we're just completing the follow-up of this study. It's been quite tough during the pandemic, but we think we're going to get there quite soon. So it'll be interesting to see the prevalence of microvascular disease in this population and whether disclosure of the test results in this stratified medicine approach might make any difference to the patient's well-being down the line. This is the population characteristics. So 62% of the patients enrolled and randomized are female. And again, there's cardiovascular risk factors are fairly prevalent. Carmichael involved 151 patients, mainly in the Golden Jubilee Hospital. There was another hospital involved, but it should be considered as a large pilot study. So we are now escalating to an international clinical trial called iCarmica. This is the design of the trial. It's currently running. We're looking to randomize 1,500 patients in a fully double-blind protocol with stratified medicine guided management versus standard care. And Seattle Angina Score, as well as clinical outcomes, will be evaluated. This is the schedule of assessment. So we're asking patients to complete angina questionnaires quarterly, and we'll subject these questionnaires to clinical event committee evaluation. And then just finally to the PRIZE study, precision medicine with zibotentan in microvascular angina. So in this study, there are two themes or concepts underpinning the design of this study. So first of all, that small vessel disease is influenced, if not indeed driven, by abnormalities of the endothelial system, and that some patients may have a genetic predisposition to microvascular dysfunction leading to angina. So this is a precision medicine study where we are enhancing the patient population with a SNP G allele genotype that might enhance endothelin production. And it's a randomized placebo-controlled crossover study, which again has been quite a challenge to run during the pandemic, but we're getting there. It's 100 patients randomized, so it could be considered as a phase 2 study. And the duration on the Bruce treadmill exercise protocol is the primary outcome, the within subject change on treatment. Multiple hospitals across the UK are supporting this study. It'll probably take another 18 months to complete. So to conclude, and I hope I haven't gone on for too long, INOCA, ischemia with no obstructive coronary arteries, is a new term which we can consider as opposed to using terms such as syndrome X. INOCA is common, probably under-recognized, including in relation to diagnosis and treatment. The Carmichael trial probably was the first to introduce stratified medicine into ischemic heart disease, and it did return favorable results, which require external validation in the larger studies. In terms of future directions, I would like to think that we can educate onto more unbiased approaches in the way that our patients are managed. I haven't talked about MINOCA, but could do. And we look forward to new drugs for disease-modifying treatment to offer to our patients with ischemic syndromes due to small vessel disease. So with that, I'll stop. I could maybe come off screen share. Should I do that, Rohan?
Sure, if that's what you prefer.
Yep.
Absolutely.
There we go.
Thanks so much. That was such an excellent talk and such such a great overview of the entire stream and the history of the entire topic. Obviously we'll have a lot of questions. I've been kind of trying to keep track of who asked questions first. So Dr. Mani, Ari Mani, I'm going to have you ask your question.
Yeah, this was an excellent talk and very relevant. You mentioned that discontinuation of medical therapy led to poor prognosis, and I wonder, do they have patients with micro and microvascular disease, same risk factor, or the microvascular is more hypertension related? And a relevant question actually, has anybody done post-mortem to see at the microscopic level? Is it atheroma? What is it exactly, this microvessel disease? And then second question is that you are doing endothelin SNP. Why not doing an unbiased and looking at the many SNPs and see what is going to be actually the genetic predisposition? Thank you.
So thank you for that question. So to the second question, that work will be done. So there's a parallel study running in Cambridge, which is looking at, or will look at, the associations between different SNPs and exercise duration and indeed treatment response. And that study is affiliated to the PRIZE study. So every patient going into PRIZE is providing bloods for genetic and transcriptomic biomarkers. To your first question, which was around anatomical and pathological correlations, I think you're right that there is a gap there, an information gap, probably because of the challenges in obtaining biopsies in vivo from such patients who ordinarily do not have an indication. There are some parallel studies in patients undergoing coronary bypass surgery, and for example, there's some correlations between hypertension status and fibrosis in myocardial tissue. Although that's not the question that you asked me, you're asking specifically about patients with coronary vasomotion disorders, and really there's very little. I think just to complete my answer, there is one manuscript from Xavier Esquinet's group in circulation about 10 years ago. Perhaps animal models could be informative. Genetic models of endothelin, enhanced endothelin production, and actually that's an area I'm starting to work in, and it will be interesting to see whether prolonged exposure to endothelin leads to microvascular remodeling and fibrosis in the heart. Thank you.
Perfect. Next to Dr. Zarif.
Yes, thank you for a wonderful talk. In the past, there was investigative interest in other non-invasive approaches to defining microvascular dysfunction, plethysmographic techniques that related to reactive hyperemia and other techniques as well, making the assumption that the endothelium looked at in different vascular beds would have distinct pathologic and normal functional relationships. You didn't mention these at all. Do you think there's any place for these approaches in the screening of patients for ANOCA?
Yeah, thank you. So apologies that I didn't go into that area, I suppose, because of time constraints. So, of course, there are bodies of work. I'm coming to mind, Arshad Qumi at NIH, and now at Emory, and Amir Lerman, and I could go on. To the question of whether this could be clinically applicable, I think what we would really need to see is a randomized trial where patients are enrolled based on abnormalities on such metrics. Symptoms are evaluated, angina symptoms and quality of life are evaluated at the start, and then therapy interventions introduced in a randomized way. So if such a study demonstrated patient benefits, then that would support using peripheral vascular assessments in this patient population. I do think we are some distance away from that. I think the tractable targets for testing are in the tests that we normally use, which is in stress testing in the outpatient clinic setting, and probably in the cath lab also. Thank you for your question.
Thank you.
Next up, I have Dr. Berg and then Dr. Spatz.
Yes, thank you. Just want to echo everybody's comments about what a really great presentation this was, and good to see this increasing focus on this clinical presentation. research that we've done here and that, Viola Vaccarino and Arshad Fiumi and the group down at Emory have done really points to, a different set of provocative stimuli that are associated with ischemia in the setting of INOCA, where physical stress may not be the best provocateur, but psychological stress is, and that hints to a role for the autonomic nervous system, and thinking about that in relation to endothelial dysfunction. And beyond that, Viola Vaccarino's, some of her data suggesting that lifetime trauma or the circumstances under which people live, social determinants of health also playing a role here.
Yeah.
When we think about the patient as a whole, rather than just the biology or the pathway, can you speak to that whole element where what we might be seeing is a phenomenon that is driven in part by the autonomic response to conditions of living and psychological stress?
So I appreciate that question. I think it reflects the patient, your question reflects the patient voice and the individual patients that I'm sure you have and I have in our clinic. When they speak with us about the symptoms that they have, they're placing those symptoms in the context of their own lives and social factors, workplace issues. I can think on so many patients who've had work-related stress that has kind of driven a deterioration in their anginal symptoms. And yeah, I can think in two individuals where quite literally they went through HR processes that resolved favorably, and ultimately the stress was relieved and their angina got better. And more specifically, I think studies in relation to autonomic challenges, cold pressor tests, etc. There is a wealth of literature on mechanistic studies associating physical and environmental stressors in relation to deterioration, short-term deterioration in vascular function that might probably be measured peripherally, but also I suspect there are some studies looking at coronary circulatory responses as well. So I think that's very important. And I apologize that I didn't give that more traction in my talk.
Dr. Spatz?
Sure. Thank you so much, Dr. Berry. I wanted to really make a comment about how foundational and inspirational your work has been. In 2008, we did the Virgo trial, of study of young women with heart attacks, and 1 in 8 women had no thrombosis, and 1 in 5 women had no identifiable mechanism. And then we were, aware theoretically of the different endotypes, but really lacked the tools to be able to diagnose women. And so here at Yale, Dr. Sunit Shah has established our invasive coronary physiology lab, and it's really been just entirely powerful and a complete game changer in how we care for women. We have a medical student who spent the last year with us doing qualitative interviews with women who underwent invasive coronary vascular testing to establish their diagnosis versus women who were just given a diagnosis of INOCA. And their stories are incredibly powerful about how they lacked names and terminology, that they were dismissed by the medical system, further confounding known gender disparities in this area. So the Cormica trial, I think, proved to everyone that that these diagnostic techniques are safe and that they are incredibly useful. And especially, I wanted to, kind of hear your comments a little bit more on the treatment end. I mean, so much of our treatment has been stymied by not being able to stratify the different diagnoses and really prospectively test different medications. And I know we in our group, Dr. Shah and I, struggle with effective treatments. It still feels like we, do go through a trial and error process. I think women with a diagnosis are more okay with that because they feel secure about what they have and what they don't have. But it's still a pretty big challenge in the clinical space. So
first of all, I would commend you for the Virgo study. It's one that I go to in writing grant applications and so forth. It's a real source of reference information. So congratulate you and your colleagues for that study. So to therapy. So I think that the therapy question is a difficult one because we really are repurposing medications that have been established in coronary heart disease, in other words, in different indications for angina due to obstructive disease. Not to say that these treatments, beta blockers, nitrates, and so forth, are ineffective. In fact, quite the contrary. In Carmichael, we went into that study with open thought, and I had no idea what we were going to see when the results were disclosed. But nonetheless, when we used these treatments in what I think was a logical way, we did see patient benefits. And to my experience with individual patients, and I think this is what you're probing, is that we use a logical and a somewhat empirical approach to achieving an effective treatment plan for our patients with INOCA. But by and large, it's now my experience that I am able to make appreciable improvements in patient symptoms. Not always, of course, and sometimes the symptoms may deteriorate, but I generally have a sense of optimism in my outpatient clinic that I can make patients better based on this type of practice that I've described to you today. But hopefully in the months and years ahead, we'll have treatments that are specifically indicated based on trials like PRISE and others that will hopefully follow.
Sorry. So a couple comments in the chat, but I'll let Dr. Bender and Dr. Cohen ask their questions first.
Larry, would you like to go?
Thank you, Jeff. Dr. Berry, you've raised many questions, and thank you so much for that. In the Carmichael trial, I note that 74% of the patients in the trial were female, and many of them were elderly. My question is, did you see in this group any increased incidence of the Takotsubo syndrome, where estrogen lack is usually a central feature, the so-called broken heart syndrome? So my question simply is, did you look for that? And if you did you find it?
So thank you for your question. I think in truth, we did not specifically look for that. On the other hand, our studies of modest scale, there were 151 patients. And the other caveat is that our study population mainly had stable symptoms. They were not an acute population. We are starting a study in acute patients with no obstructive disease, that is MINOCA, and they are definitely, we might observe a proportion of patients with Takatsubos. So I think probably the information that I have available is insufficient to fully address your question. But I think your point is well taken about estrogen deficiency and Takatsubos in this type of patient population overall.
Thank you.
Yes, Dr. Berry, thank you for that terrific talk, and congratulations on all your outstanding work. Not to beat a dead horse here, but I just wanted to circle back a little bit to a distinction that you referred to and came up in some of the previous questions. One tends to talk about epicardial versus microvascular in these discussions and in this work. And of course, you know, and you refer to it, that it's equally important, I think, to define whether whatever the defect is mechanistically is at the endothelial versus the smooth muscle level, because that would have tremendous differential therapeutic implications. And a couple examples of that. One is you're talking about endothelin. There are endothelin A receptors at the smooth muscle level that are vasoconstricting, and there are B receptors at the endothelium that drive the release of nitric oxide that are vasodilating. So antagonizing endothelin pathways could give very different types of results. The other thing is all the young women with coronary syndromes. A big question of ours, and I think in the field, is whether the XX and the XY endothelium are different, or whether this is tremendously hormonal, or whether it's something biologic about the vasculature that drives the difference in gender that we see in these syndromes. So I think to define, this is a general comment, and I know that you probably think about this all the time, but smooth muscle versus endothelium, I think, is critical to define.
So your points are, you've described the problem very eloquently, and of course I agree with you, and I understand well the detail that you're referring to. Like many here, I've come into this space from a clinical perspective. I've been trained with the angiogram only for many years, and it could well be in the years ahead that we get to an approximation where a clinician in the outpatient clinic or in the cath lab can have better tests for more specifically identifying mechanisms. And of course, those tests, they could be in the form of biomarker tests. They could be in the form of refined acetylcholine protocols. One of the big issues with acetylcholine, of course, is it's not licensed, and there are various regulatory and medical legal issues around. So I think we are at one point in a journey.
Thank you.
I want to make sure that our fellows have an opportunity to ask questions, and one of our clinical fellows, Dr. Jackie Perez, is on. I want to have her ask her question, and there's another fellow question in the chat that I'll bring up after that. Go ahead, Jackie.
Hi, Dr. Berry. I'm one of the first-year cardiology fellows.
Hi.
You had a slide up where you sort of showed that in the future we should maybe consider that microvascular disease is beyond the myocardium. So I'm actually curious about whether you think that in the next decade, that we'll see a paradigm in treating these patients where we are screening for retinal disease and renal disease in the same way that, we try to do for diabetic patients, because I wonder if that will have an impact not only on their outcomes, but in terms of patient voice and feeling that we're taking care of the entire patient.
So this is a big question you've posed. Some of my patients, they'll turn around and they'll say, am I going to get dementia, doctor? And well, my answer to that is, of course, I don't know. Yes, there theoretically could be an association, but we don't have evidence of that. I would circle back from a practical perspective. So undertaking the tests that you appropriately allude to, there are considerations around the time, the cost, the analysis, and then, of course, what do you do with the results? Well, it could be a wonderful cohort or epidemiological study, but actually, if the patient certainly is in the cath lab, and the Copenhagen study told us this, that these individuals are already at increased vascular risk. So maybe putting aside the value of specific mechanistic science, maybe treating one problem well will be helpful for vascular disease in other beds. But thank you for your question. It's well taken.
One last question from one of the fellows. I'm going to pose that from the chat, and then Dr. Velasquez will do the last, the sign-off. So for Amar, who is one of our fellows, had a question about a recent study in circulation research about intracoronary autologous CD34 positive cell therapy for coronary endothelial dysfunction. That and many other stem cell therapies have been proposed in this domain. So I would sort of like pose that as a general question, and then I'll hand it off to Dr. Velasquez.
Thank you. Well, CD34 cells are a form of hematopoietic vascular progenitor cell. I think there's more than theory to constitute the fact that these cells are biologically active and in favorable ways to the vasculature. Whether that laboratory science can translate meaningfully into a therapy for patients, I think is a big question, and an expensive one as well. I'm generally aware of the research that's been done, but not specifically in terms of the exact details of the study you refer to. But I do think there is quite a journey to go before we can offer such a treatment to our patients in the full knowledge that we can expect some level of benefit to be conferred.
Thank you, Eric.
Sure. First of all, Colin, thank you so much on behalf of Yale Cardiovascular Medicine, the entire team, for a tremendous talk. I have a few comments, maybe one very quick question. I know we've over time, but you can imagine there's been tremendous excitement about your talk and a lot of great questions.
Thank you.
First, I would say, please say hi to my friends, many, John, Mark Petrie, the other John,
Yes.
if he's still there. And I would just suggest that, you've shown us a compendium of studies and an approach that is so very exciting about how to evaluate and manage your own patients as a source of, establishing, new approaches. And I would very much be excited, and I think I could speak for the team, to be a collaborating site on many of these studies. And as you think through, your program development, we have our own small institute, governmental institute, that's still funding some studies. And so we would be glad to go into these together or at the secondary site. So that's just one comment.
Thank you.
Congratulations to that. My question relates to your perspective and maybe your team's approach clinically to that population, which Erica, I think, mentioned, but I think is, to me, integrated, which is the HFpEF population. And I'm curious if you approach these patients as ischemic equivalents and do this kind of evaluation. And if you have, what have you learned so far?
So I'd like to speak to a study that we have undertaken. It was highlighted in one of the slides, and it's published in JAMA Cardiology last year. First author is Rush, R-U-S-H, Chris Rush, and Mark Petrie and John McMurray, and I contributed to this. And in that study, patients who had been hospitalized with heart failure and had, let's say, a validated diagnosis of HFpEF were invited to undergo invasive coronary angiography, coronary function testing, and stress perfusion CMR. So I think the first main finding was that coronary atherosclerosis was very much prevalent in these patients. And also microvascular dysfunction was also, I think, about 2/3 of the patients had an abnormal microvascular response. And they had the full IDP protocol with acetylcholine testing. So I suppose the question, though, is it cause or effect? And, a patient with a HFpEF phenotype with myocardial hypertrophy and so forth, you might anticipate that they might have microvascular dysfunction. So our cross-sectional study could not answer that. There are other studies on stress perfusion CMR with impairment in vasodilator responses. And in terms of practical translation, I think it would be ideal to have a randomized trial that enrolls a HFpEF population or subgroup with such abnormal responses, randomizes these individuals to some logical treatment, and then demonstrates that the abnormalities have improved and the patient well-being has improved in some way. And if that evidence were to become available, and to my knowledge it is not available at this time, then there would be a compelling indication for doing stress perfusion CMR or cath lab testing in these patients.
Great, thank you. And again, thanks very much for participating with us today. I look forward to hopefully collaborations into the future, and
Yes.
Someday we will have you here in New Haven as well.
Very kind.
Okay.
Welcome you to Glasgow as well, whenever that might be possible.
Yes.
Thank you for your time.
Okay, everyone.
Thanks a lot. Thanks, everyone. And we'll see you next week.